Households face severe financial consequences when members become ill. How can health systems provide necessary financial protection to avoid financial hardship or even poverty due to illness? Welcome to the Health Systems Transformation channel, dedicated to promoting health systems strengthening globally. In this episode, we will review financial protection in health. I am Cristian Baeza. Join me in this journey of how to improve health systems around the world. Subscribe. Welcome, and see you in a moment. Welcome back. This is our third episode in Transforming Health Systems. In the first episode, we got an overview of what are health systems and how do they work. In episode 2, we began reviewing the health system's objectives by discussing health and the role of health systems in protecting it. In episodes 4 and 5, we will review in depth health system financing. In this, our third episode, we will look at what is financial protection, how do we measure it, and examples of financial protection failures, as well as begin discussing about what can households do and policymakers do to ensure financial protection for all. Thank you for joining us. As a reminder, when analyzing health systems, we need to examine two key dimensions of it: the health system objectives and the health system itself, which is functions and components. Societies expect health systems to achieve at least 4 objectives simultaneously: good health outcomes, financial protection for all, responding to the legitimate expectations of citizens regarding the health system, and system sustainability and its contribution to country development. Let's now review the financial protection objective of health systems. Households and individuals potentially face significant negative financial consequences when affected by a health shock, being it illness, an accident, or even normal life cycle events like a birth of a child. In the absence of effective protection, the financial consequences can be catastrophic and throw them into poverty. In the United States, the majority of personal bankruptcies were related to health in 2007. Financial hardship due to health shocks is a global challenge, as shown in this graph from our Beyond Survival book, illustrating the results of large surveys in Chile and Peru in the early 2000s. The graph shows the response of large sample surveys to the question of whether the family had faced events that have caused significant income losses. In both countries, the majority of respondents had faced such events, and in both countries, health shocks were the second most important driver of loss of income and financial hardship after macroeconomic recession. Global evidence shows that health shocks can cause severe financial impact on households through at least 4 drivers. First, large out-of-pocket expenses for health service, being them caused by an acute health shock like an accident, or being them caused by a prolonged costly disease such as treatment of diabetes and hypertension complications for life. Second, acute loss of income due to a health shock, making it impossible for a family member to continue working and earning a living. Third, long-term loss of income due to reduced participation in the labor force as a result of disability. And fourth, I increasingly add the potential driver of excess contribution or cost of getting effective coverage for the missing middle population in predominantly contributory health insurance schemes. This is population that aren't rich enough to purchase voluntary insurance but aren't poor enough to be covered by fully subsidized public programs. For these populations, the contribution itself may become unaffordable or severe financial hardship. So, what is financial protection in a health system? Financial protection is, in essence, the objective of ensuring that households can access necessary services without facing financial hardship when ill or when facing normal life cycle events related to health. How do we measure financial protection? Ideally, we would be able to account for any expense related to health that substantially hampers the household consumption of goods and services that are essential for their long-term creation of human capital, critical for their success in society. Food, education, housing, preventive health care, and many others. That would allow us to really capture the essence of hardship in financial protection. However, this is impossible in practice, which has prompted for the development of proxy metrics. Out-of-pocket expenses are the core building block metric of most commonly used metrics in financial protection. They are very helpful basic metric in analyzing financial protection, but they are by no means perfect and require careful interpretation of data findings. Out-of-pocket health expenses are, in summary, any payments for health services made directly by the household, excluding reimbursements by a third party or contributions to prepayment schemes, such as health insurance premiums or payroll taxes for social health insurance. They can be in cash or in kind. Large amounts of out-of-pocket expenses have very negative consequences for households. They are a major barrier for demanding services. They expose households to large acute expenses or catastrophic expenses. They are regressive in general, as the poor and near poor tend to expend a larger share of their income in out-of-pocket than the rich when services are available. And catastrophic expenses expose households to poverty due to illness. There are two main financial protection metrics most commonly used today, both based on out-of-pocket expenses, catastrophic out-of-pocket expenses, and poverty due to illness. Catastrophic expenses are defined as out-of-pocket expenses beyond a defined proportion of total household income, typically between 10 and 40% depending on different analyses. Catastrophic expenses are the official Sustainable Development Goal indicator for financial protection, defined at a 10% of total household income. Poverty due to illness is defined as the proportion of non-poor population whose income, net of out-of-pocket expenditures, is forced below the country poverty line due to health expenses. Let's look now at one real country data case. In this graph from the Honduras LSMS 1998, we will examine the impact of all out-of-pocket expenditures in all survey households in the country. The y-axis represents the household's income in multiples of Honduras poverty line, beginning at zero income level. The green line represents the Honduras poverty line in 1998. The pink line plots all LSMS households surveyed in ascending order of income, with households below the poverty line on the left and above poverty line on the right, all before subtracting out-of-pocket expenditures from their income. Let's review the impact of out-of-pocket in three real household examples. The vertical blue line indicates the effects of out-of-pocket on household income, indicating the pre-out-of-pocket income on the top and the income net of out-of-pocket on the bottom. In this first case, a non-poor household loses a significant part of its income due to out-of-pocket, more than 10%, which would classify as a catastrophic health expense, but the net income is still above the poverty line. In this second case, a near-poor household suffers a similar significant income loss due to out-of-pocket, much more than 10%, which makes it catastrophic health expense, but it also brings their income well below the poverty line and below the zero income line, which means they not only became poor, but incurred substantial debt and negative savings. In this third case, an already poor household also suffers a very significant loss of income and assets, deepening its poverty. It is also a catastrophic expense, but unless depth of poverty is measured as used by WASTAF in 2018, the impoverishing impact will be underestimated. This is the actual data from the Honduras 1998 LSMS showing the out-of-pocket effects for all households. It shows a very high incidence of catastrophic and impoverishing health expenses, including substantial deepening of already existing poor, all signs of a major financial protection problem in the country. Unfortunately, the Honduran case is not an isolated one. Let's look at more recent international evidence on catastrophic and impoverishing health expenses. This figure, adapted from the Global Review of 133 countries published in 2018 by WASTAF and others, shows the trends in proportion of the general population that faced catastrophic expenditures from 2000 to 2010. In addition to show significant incidence of catastrophic expenses, it also shows that incidence grew globally by 21% in the decade. There are important differences among regions. These differences need careful interpretation, especially because in low healthcare supply contexts, low out-of-pocket may induce wrong conclusions, as I discuss later in this episode. Similarly, this graph highlights significant incidence of non-poor population being pushed into poverty by out-of-pocket in 4 countries in Latin America, with a range of new poor from 1% in Chile to 11% in Ecuador in 2004. Most countries in the world aim at reducing out-of-pocket, and many have done so substantially in most regions. However, a number of countries in South Asia and some in Asia have sustained challenges achieving this goal. Although there is no consensus about what is the optimal level of household out-of-pocket, very high levels of out-of-pocket of 50, 60% or more are definitely a major sign of lack of financial protection and need to be lowered effectively. There is consensus, however, that no household should face catastrophic and/or impoverishing health expenses. This means eliminating all out-of-pocket for poor households, as they are already poor, and any out-of-pocket would deepen their poverty. As we can see, out-of-pocket expenditures are very helpful indicators for financial metrics. However, results from both the out-of-pocket themselves as well as catastrophic and impoverishing incidents due to out-of-pocket need to be interpreted very carefully. Out-of-pocket data and their derived metrics must be interpreted together with access and utilization of services. Low out-of-pocket may be indeed a good sign of low exposure to health expenses, but it may simply mean no utilization of services. Let's look at one example from Ecuador in 1998. The graph shows the average out-of-pocket by income quintile. Data shows that on average that year, the poorest quintile spent 11% of total consumption in health out-of-pocket, while the highest income quintile spent 6%. However, when standardizing expenditures by service utilization, this is adjusting by what would be the expected out-of-pocket if all quintiles were to use services equally at the level of the third income quintile, the poorest households out-of-pocket almost double, while the rich ones are reduced. What drives failures in financial protection, and what can households and policymakers do to solve them? No doubt that social determinants beyond health systems, such as poverty, social inclusion, and many others, play a critical role in catastrophic and impoverishing health expenses. No health systems policies or transformations will suffice to address financial protections in the absence of these complementary policies to address its social determinants. However, health system policies and design also play a key role and can help. Let's look at them. All health system components play a role in ensuring financial protection to households. However, the risk pooling function in health systems financing is perhaps the most determining component of a health system capacity to provide financial protection. We will review financing in detail in episodes 4 and 5, including a detailed discussion of what is risk pooling and how it is organized and managed. Risk pooling is at the core of the insurance function of a health system. It allows households to prepay or contribute, aggregating those contributions in a way that ensures that financial risk of health shocks is borne by all members of the pool rather than by one individual household. Inclusion in risk pooling is a critical necessary condition in most cases, but it is far from sufficient. Well-performing additional system components are essential. Risk pooling is not effective in the absence of a benefit package that includes services and interventions effective to address the most prevalent drivers of catastrophic and impoverishing health shocks. It will not work also if there are no providers for those services. The stewardship function also plays a crucial role. Risk pooling effectiveness is severely affected by regulation failures, such as minimum burning ratios or lack of protection regarding pre-existing conditions. Governance failures also severely hamper the effectiveness of risk pooling schemes. Unfortunately, there are too many examples of these failures around the world. Finally, a good risk pooling scheme is of little help if there is no demand for it. It is critical to influence demand for participation in risk pooling so people join, or, if it is mandatory, they do not evade participation. This is a key challenge in the participation of the informal non-poor households in risk pooling, often aggravated by mistrust resulting from regulatory and governance failures. Health systems risk pooling plays a central role in financial protection, but it is not always the only or sometimes even the best alternative for households or policymakers to ensure financial protection for all. Households and policymakers have other complementary policies or instruments for ensuring financial protection for all. We need to use the best combination of available instruments and policies to match each specific driver of catastrophic or impoverishing out-of-pocket. The cornerstone option for financial protection is risk pooling. Other options include direct public subsidies, savings, prevention, prepayment schemes, regulated voluntary insurance, and other. We will review them in detail when we review health financing in episodes 4 and 5. Health shocks characteristics such as frequency, predictability, size, cost, externalities, and other need to drive the choice of policies and instruments to be combined. As I do in every episode, here are some reading recommendations to further review financial protection in health systems. To further explore financial protection and its relationship to health systems performance, I recommend to review 5 very helpful readings. The World Health Organization World Health Report 2000 on Health Systems Performance. Beyond Survival, authored by Truman Packard and me, that provides an in-depth review of financial protection policies and instruments. WHO's World Health Report 2010 on health financing and universal health coverage. And 2 excellent articles published by 2 outstanding global thought leaders in health system financing. The first, a 2013 conceptual review of health financing and universal coverage by Joe Kutzin, published by WHO's Bulletin, and the second, published in 2018 in The Lancet by Adam Wastav, reviewing progress on catastrophic health spending in 133 countries. Adam is unfortunately no longer with us, but his amazing research and legacy continues to guide us around the world. Thank you for joining me in this short review of financial protection. Please share your comments and suggestions. In the next 2 episodes, we will review health system financing, including revenue collection, risk pooling, and strategic purchasing. Thank you for joining us. Subscribe and see you next time in Transforming Health Systems.